From San Francisco, it's Grumpy Old Doc with Dr. Gene Bede.
Hello, this is Dr. Gene Bede, and welcome to the Grumpy Old Doc. You know, we like to bring you viewpoints from a variety of people, policymakers, some entrepreneurs, patients, and also healthcare providers. Well, from a patient perspective, I'm one too. Being hospitalized for me would be a worst-case scenario. And I think for a lot of people that having a bunch of strangers now poking at them is pretty terrifying. Quarterback of this team of strangers at the hospital is probably another stranger, someone called a hospitalist or I never know which syllable to put the accent on. I call them hospitalists. Some folks call them hospitalists. But that's a relatively new breed of doc. They care only for patients in the hospital. With us today is a hospitalist who recently left the specialty, but not before practicing medicine for 35 years or so in that hospital environment. I'm proud to welcome to the show Dr. Dennis Schexnayder. Before we get to our discussion about hospitalists, why don't you tell our listeners a little bit about yourself?
Good day, everybody. First of all, I was born in Louisiana, Cajun country near New Orleans, and attended Tulane University in New Orleans for undergraduate and medical degrees, and then proceeded to complete my internal medicine residency at the Mayo Clinic in Rochester, Minnesota. And then I've had kind of two careers. My first 19 years, I practiced traditional, old-fashioned internal medicine, which is pretty much office medicine, hospital medicine, seeing you in the emergency room. I kind of went wherever my patient needed my care, and I did that for 19 years. And I also did some academics, did a little bit of resident and intern teaching in the course of that 19 years. And then in 2002, I decided to devote myself fully to hospital medicine, the so-called hospitalist concept or model. And,
we are both having trouble with the accent on the wrong syllable there, I think, but go ahead.
Yeah, it's a tough
I think it's a regional thing, too. From Louisiana, I bet you they say it different than they do in Boston.
Probably so. I would say that would be the case. Yeah. I basically decided that since I liked the acute care medicine and the hospital environment more, I elected to do just that type of medicine, which is hospital medicine, or I was a hospitalist. I first entered hospitalist practice in Gulfport, Mississippi, became the co-lead hospitalist for a large hospital there, and I was really enjoying myself for about 3 years, and then Hurricane Katrina comes along.
Ouch.
And not a good experience for me. It was not good. Home went into the Gulf of Mexico. Hospital was damaged but still functional. My wife lost her medical practice. So we were kind of not in too good a shape there.
Now, you live in the Bay Area now, Dennis, right?
Yeah, I live in the San Francisco Bay Area in San Luis.
So I dearly hope that you don't have some sort of jinx here. The big one, if the big one hits while you're living here, Dennis, no one will want to live in the same town as you.
Yeah, because I have experienced a lot of the major catastrophes. I've experienced tornadoes and floods and hurricanes. So I haven't had a real earthquake yet, and I hope I don't. We joke a lot about it since moving here, but I certainly hope it never.
Well, we're lucky that Katrina and Gulfport, Mississippi's loss became the Bay Area's gain with both you, and you referenced your wife, who's a doctor as well. She's practices more traditional internal medicine, or is she a hospitalist as well?
No, after we ended up moving to the Bay Area in 2007, she did work with me as a hospitalist for a couple of years until she could kind of decide what practice she would join for traditional medicine, and then she ended up going into office-based internal medicine practice, which she is still doing as of today in the Bay Area also.
New Orleans' loss is certainly our gain. So tell us a little bit about hospitalists. Now, you're an internist, you said, by training, and did you do additional training to become a hospitalist? Do hospitalists do additional training to be doing that? Are they all just general internal medicine folks, or is there now residencies for internists that specialize? Tell us about how this all works.
For my particular situation, there was no real special training program. I was an internal medicine physician. Most hospitalists nowadays in the United States, about 89% or so, are internal medicine physicians, just as myself. 5% or so maybe pediatrics, and 3 or 4% family medicine. So those are the three main groups who become hospitalists. And there are over 50,000 hospitalists in the country now, and 75 to 80% of hospitals use them, and all major academic institutions do also. As far as training, hospital medicine, it's part of our internal medicine training. A lot of the work you do as an internist is in the hospital, so you already
most
have a
of it
lot
really
knowledge.
is. When we were in training, I remember there was a lot of lamentation that we don't do enough ambulatory when we're training, and they at that time tried to establish ambulatory internal and ambulatory pediatric programs that got you out into the community a little bit more, because you're right, you spent most of your time in the hospital in training.
Yeah, at least half of my time for the first 19 years I was spending in the hospital and the emergency room and the intensive care unit, so I was very well prepared to do all hospital type of job. Nowadays, it's kind of growing specialty of medicine, and there are over 50,000 hospitalists now in the country. Now they're looking at having more formal training programs. So in some internal medicine residency programs, if you know you want to do hospital medicine right from the beginning, you can actually do special tracks of training where you can get the extra expertise in critical care and procedures and things that you're going to need to know how to do as a hospitalist.
So they sort of bifurcated the traditional internal medicine residency to accommodate this sort of career path for people.
Exactly, yeah, and I predict as we move forward, more and more major academic institutions with residency programs are going to have that designated hospitalist track, because there's good and bad with all of this happening. Obviously, it's good to have a person who is dedicated to hospital care, who's on the site all the time and can attend to your needs rapidly, but then you also lose a lot. You lose that really good doctor-patient relationship and the connection with the patients and families and all of the knowledge you gain from taking care of people in the office. The hospitalist has seen you for the first time, and he starts asking you lots of questions, and you don't want to necessarily answer all of those questions, which you've told your primary doctor about already, and it's just repetitive and a lot of overlap. So some people don't like it, but I think overall it's a good experience for most people.
For me, my viewpoint on it is that I suspect that the care that you get is technically better, and I think if you avail yourself of it, the communication is probably better. Because I remember when I was in practice, just like you, I had a traditional practice, ER, office, nursery, that's another thing for pediatricians, and hospital. And people would literally be waiting for you with bated breath at the end of your office day when you would go to the hospital. They'd been waiting all day to talk to the doctor. It's got to be a lot different when there's a hospitalist on site, despite the downside of the doctor that they talk to isn't the doctor they've talked to for years.
Exactly. Most of the people we take care of in the hospital setting are admissions from the emergency room, and they're really sick, and the ER doc is seeing a patient and identifies them as being sick enough for admission, so they immediately call me. I'm in the hospital. I finish what I'm doing. I proceed directly to the ER. I examine them, take a history, do all of my admit orders, and then they get moved to their room, and then I go and resume my round. So I promptly take care of them and move them along in the system instead of them waiting perhaps for hours until their primary care doc can leave his busy office and go to take care of them. And, of course, in busy offices, a lot of patients are waiting to see the doc, and a lot of them are ill and have complex issues. And if you walk away from them, then everything gets messed up for the rest of the day for everybody.
Yeah.
So this kind of, it fragments things, but it does make things speed up a lot. And I do think that communication, we can get to people and talk to them sooner, and we do communicate with the primary care physicians. I would call them up frequently and email them and text them and try to get more information about their patients. So for the most part, when I put a lot of effort into it, I got a lot back, and the patients got good care. But, it has the potential for some people, not to work out as well. But
yeah,
I think for
you
most
mentioned
people,
emergency room, and I think that's the part of the hospital that, like, people end up in these days. The elective admissions from the tidy little admissions for the little old lady in congestive heart failure that's being admitted to diurese, those are gone. People end up in the hospital through the emergency room. We're going to have an ER doc on sometime talking about the flow. Maybe we can have you back talking with the ER doc. I think that would be interesting, because I have a feeling there's a little friction once in a while between the ER doc and the hospitalist, but maybe I'm wrong.
They're being watched numbers-wise. People are counting every minute from the time the patient checks in to when they get out of the ER and get admitted. So they want to move them through quickly. But what they do a lot of times is they don't do a thorough assessment and don't get all the test results back. So they're calling me to go admit a patient before the test results are even in. And then sometimes I show up to admit the patient, and the patient that they're telling me has a pneumonia probably needs to be admitted. I get there, and there is no pneumonia when I see the X-ray. And then I can't, unless there are issues documented, I can't admit a patient.
And the whole family's like, how come? Is this to save money? We were told Grandma's getting in the hospital because she's got pneumonia.
Exactly.
What's wrong
so
with
the
you?
family's been told Dr. Schexnayder is coming down to admit your grandma, and I show up and say, well, Grandma's going home. Well, she can't go home. She's weak. But I'll say, but her tests are all normal, and she looks pretty much normal for an 85-year-old, and so I'm not going to admit her, and then that can cause problems. So that's one area of friction. So we always hope that the emergency room physicians get us all of the information we need, and most of the time they do a very good job, but every now and then you'll get that one uncomfortable one. So
how about other things that made you irritated in the hospital environment? I just saw the other day, it wasn't real, it was tongue-in-cheek, on a Facebook page called Gomer Blog, where they said we had the first hospitalist consult by an orthopedist. He couldn't find his car in the hospital parking lot, so he called a hospitalist consult to find it for them. I got to give a little chuckle about that, but I'm sure there's other things like that that sort of irritated you as a hospitalist.
Well, I'm happy you're mentioning that one, because, like, I can think of one of my last weeks of working as a hospitalist when I got a consult from a plastic surgeon. He was the primary doc. The patient had been in the hospital for 49 days with multiple procedures, and I get a consult on the day the patient is going home, and I'm wondering, what's going on here? Patient's getting discharged this afternoon. I show up to see the patient, and he consulted me to write their prescription for a blood pressure medication, and then I got a note from the nurse saying, the surgeon said that he wants to know, can you take care of the discharge paperwork and discharge summary for him? So he basically consulted me after 49 days to write a prescription and to do a discharge summary.
We used to call that a dump back in the day.
It's a dump. Happens very little, but when it does happen, it gives you a feeling that they've got a lack of respect for what you offer to the healthcare team.
Well, I think they've got a lack of respect for their patient as well. If they think that someone's best served after a 49-day hospitalization to have their travails summarized by somebody who's known them for 24 hours, that's a travesty of good documentation and good clinical care.
And you'll hear nurses or patients' families talking out in the hall. After a hospitalist has made rounds and has left the room, they'll say, he said Mom is sick, but he's only a hospitalist. Like in saying it in kind of a derogatory terms, when I hear that, it really upsets me, because I really take good care of my patients as a hospitalist, as good as I did when I was a traditional.
Maybe they think when you're not seeing patients, you're buffing the floor. You're one of those guys that's making it nice and
smooth. But a hospitalist can offer a lot to the healthcare team, and so that's one big area that's a pet peeve, and the workload. We start out with many patients to round on every day. They're sick. They have a lot of needs. And then unpredictable workload also. You start out busy, and then you might get one admit that day to work up. You might get 6. You might get them right when you're ending your shift, and then you're working 3 or 4 hours.
It's very much like being a resident again and being on call, and whether you get bombed or whether you have a pleasant night or whether you have a black cloud, as they used to say, that bad things. But nowadays, it's not like, when we were in the hospital years ago, much of your time was spent doing, as you said, discharge summaries and writing progress notes and double-checking your orders. But now every hospital has electronic medical record, which really, we've been told, really has revolutionized care. Has it? Has it made things easier for you?
Well, I think overall, probably there are more pros than cons, but I do know it requires, especially when you're first onboarding on a system and learning how to use it, it does take a lot of time. There's a lot of ramp-up time. And then even when you get good at it, it cuts into a lot of time spent with families and patients. I know that when I would make rounds, I had my keyboard right there at the bedside with my monitor screen, so I was taking my history and talking to patient and family, but I had to take notes and look at stuff at the same time. And patients and families would get upset sometimes because they don't want you looking at